I'll reshare it. I think there is some internet issue.
ಸ್ಟಾರ್ಟ್ ಆಯ್ತಾ?
One second, sir. I'll restart it, sir.
ಬೇರೆ ಯಾರಿಗಾದ್ರು ಶೇರ್ ಮಾಡೋ. ರಾಜೇಂದ್ರ ಅವ್ರದ್ದು ಇಂಟರ್ನೆಟ್ ಚೆನ್ನಾಗಿದ್ರೆ ಬರುತ್ತೆ. ಫಿಕ್ಷನ್ ನಾವೆಲ್. ಇಫ್ ಯು ವಾಂಟ್ ಟು ಬೈ ಇಟ್, ಡಿಫೈನ್ ಆಸ್ಮಾ. ಇಫ್ ಯು ಲುಕ್ ಬರ್ತಾ ಇದೆ, ವಿಡಿಯೋ ಇಲ್ಲ,
Sure, sir.
audio ಇದೆ. If you want to buy it, what you do, you look at the back cover and see this summary of whatever.
It's coming, sir, now?
ಅಲ್ಲ, ವಿಡಿಯೋ ಇಲ್ಲ,
ಹೌದು ಸರ್.
ಆಡಿಯೋ ಕೇಳಿಸ್ತಾ ಇದೆ. In my days,
ಈಗ ನೋಡಿ
we have
ಸರ್.
20-25 mark question. ಇಲ್ಲ, ಶೇರ್ ಮಾಡಿಲ್ಲ. Incentive based. The
Okay.
more papers I correct, the more money I get. Audio ಇದೆ.
One second, sir. I'll again
At
reshare.
least in MD. So there is always a time frame in which I have to
Now,
correct
sir?
the papers, and as an examiner on the 50 plus side, my patience is very, very less. It's coming. Appropriate.
Okay, sir.
So as I was saying, ever since I switched to Lecturio, I felt empowered. Like I can study anytime, anywhere, and for the first time, I really can.
I'd skip one. If I find anything that is interesting and I want to check whether you know the dosage and duration, then I'll go to only that specific point and say, okay, he has answered this rightly or wrongly, and it will help me to correct. So very important is to catch the attention of the examiner, who is a senior citizen, hard of hearing, difficult to see, and he will be kept in a closed compartment, closed room, because of all the whatever safety for malpractice. And then he'll be under CCTV camera, and he has got a time. He has to finish from morning 9 o'clock to evening 5 o'clock. And DNB exam is even worse because they have done away with peripheral exam. All the examiners will have to travel all the way to Delhi, sit in a closed room. They'll give you coffee, but you can't go out for 8 hours. So the mindset of the examiner is very, very claustrophobic. He'll be very disturbed, and he doesn't have any patience to go through it line by line. And worst is when the handwriting is bad, he'll get put off and he will straight away say, I'm not going to give you full marks. So good handwriting, bulleted text in the first paragraph, and then go to explain. Very often you will get away getting pass marks just by the examiner seeing the bulleted text. Second thing is, when possible, write simple diagram. No need to write exactly what is there in the books. For example, there is something related to physiology, write simple flow diagrams. If you're able to reproduce what is there in the textbook, very well. For example, discuss the management of dengue shock syndrome is the question. Then you have all the WHO flow diagram. You all done it in your day-to-day practice. You can easily reproduce it. Or supposing there's a child with inborn metabolism, how do you approach the diagnosis? So you got an algorithm. First do ABG, then do blood glucose. You got normoglycemia, and then ABG is normal, then urea cycle defects, hypoglycemia. So you have to give a structure that you know something, and we are not asking you to do a Xerox of what is in the book, because physically impossible to memorize everything. You get the concept and you can devise your own flow diagram, no problem. But let the examiners catch this point. So examiner will easily say, I did, yes, this person's knowledge about this particular question is good. Maybe there are some mistakes here and there, one up and down. It doesn't matter. I will give him marks for this. So flow diagrams, and if possible, tables. And when possible, you can write a statement. This question I'm going to answer under the following headings. Or I want to classify the answer. For example, discuss the management of a child with noisy breathing, if they ask. Then you can say, I'm going to discuss this under 4 headings: upper airway, large airway, small airway, parenchymal disease. Then you elaborate it: upper airway, I may get nasal ragates, I may get a snoring because of adenoid enlargement, I may get swallowing difficulty because of retropharyngeal abscess, voice change may be there, stridor may be there. So like that you go on. So, but upfront I'm telling, I'm going to answer this question on approach to child with noisy breathing under the 4 headings. So I know that this fellow is very systematic and organized. And I'm going to look for some keywords. Has he written stridor? Has he written wheeze? Has he written grunting? So I'm going to look for keywords. So when I'm writing like this, again, your importance as students is to catch the examiner's eye. So highlighting the points that you want to emphasize will be very good. So tables, flow diagrams, either conceived by you or reproduced by the text, writing the answer under different headings, classifying your answer, and highlighting important points, what you want the examiner to understand. Clever students tend to quote some recent articles. If you can remember, for example, if there's something recent on asthma, if you read it recently, you just say from Lancet January issue 2021. Then I know that you have got some idea of the recent advances. So these are some of the tips that I can give you. And very importantly, your answer should be appropriate to the marks allotted. You can't write 1-page answer for a question, for a part of the question which has got only 1 mark. Or you can't write 2.5 pages if the marks is only 3 marks. So, and in that 3 marks question, you should be able to convey to the examiner that I know a lot of things, but because of the marks constraint and this thing, I'm going to highlight certain things. So emphasize what you want to stress, convey to the examiner that you have understood the question perfectly and you're trying to answer. Okay. Any doubts till now before I go on to give you some examples? Anybody can want to ask any doubts? Hello.
ಏನಿಲ್ಲ ಸರ್ so far no chats as of now.
If anybody wants, you can stop in between. I have no problem.
How important are doses is the question, sir.
If there's a question related to management, right? For example, if there's a question related to management of status epilepticus, right? The question may be define status epilepticus and discuss the management. Define will carry 1 marks and management will carry 4 marks. When I say 4 marks, you know there's an algorithm that first you give lorazepam, 15 minutes later you give phosphonatoin, then you give phenytoin, then you intubate, then so that flow diagram. So put that flow diagram and then you go on to elaborate lorazepam dose, route of administration, and look out for possible side effects. How long you have to wait before you give the next drug, and any precaution when you give drugs like phenobarbital or phenytoin. It should be given slowly, diluted in saline, drip ratio. So if there's a question related to management, we expect you to write the drug dose and duration. For example, they ask you treatment of enteric fever or treatment of COVID, for example. You should be able to tell IVIG or MIC in COVID. IVIG dose, steroid dose, how long you want to do, what are the side effects you want to observe. Even the question doesn't ask, if you write this, then I know actually you have handled a case of COVID MIC in your what. So what we're trying to look at is, have you understood the subject and are you able to convey to the examiner that I have got a fair knowledge of the question. Somebody has asked difference between management and treatment. This is a fundamental question. When you say management, it includes investigation and medication. When it's only treatment, it is just medicines. That's what is the difference. If you got a, yes, if you have a question on congenital heart disease, it is necessary at least in 3-4 lines to diagrammatically put supposing there's a question on VSD, put a diagram on the hemodynamics, use different color pencils so that the arterial side, venous side, you can this thing, and few lines for description Start from one place, the blood flows from the left ventricle across the VSD into right ventricle, across the pulmonary valve, and what are the chambers, the enlargement that you can get, and so on and so forth. Four lines you should be able to describe. What you should remember is you are not taking exam of DM level. We are looking at basics. So fundamentally, you should stick to basics, not advanced cardiology discussion. So that's what you should remember. Don't get put off by the words, complicated words what they give. Right? I hope. Yes. Okay. Now, next is what are the favorite patterns that you get in the exam? Right? What you should remember is, of course, these last few years, DNB has been a little tricky. They have stopped repeating the questions, but no examiner worth his name can invent new questions, right? So your focus should be on going to the previous year's papers and see questions which are most often repeated. In any examination, there are going to be googly questions. But be prepared to answer questions on something that has been happening recently. For example, about 5-6 years back, a lot of questions came on dengue. Then some questions started coming on chikungunya. And if you're taking exam in 2022, be sure that you will get some question on MISC, COVID, pediatric COVID, whatever, or the vaccines in COVID. So be sure to be updated with the recent happenings in your hospital, maybe for the past 1 to 1.5 years, and be thorough with this answer. It's a sure shot. Because it is current, you will be able to answer it better rather than if I ask you a question on Kawasaki. There may be a question on how do you differentiate Kawasaki from MIC. So like that, it can go on. So be very sure to go through the previous year's papers, see things which are coming very often, and in this next 1 month, focus on those topics which you are not able to write offhand. For example, the question on genetics, I find it very difficult. So I will revise that chapter thoroughly. If there's a question on inborn metabolism, right? Like, for example, if they ask you a question on maple syrup disease or PKU, I don't know anything about it. So your previous question papers will tell you what are the various IEMs that are asked. So as a rule, they may not ask you some very rare inborn metabolism. They'll ask you common galactosemia or fructosemia. So they may ask you something like that. So circle of those questions, which is difficult to memorize and remember, and at least devote 1 day in a week or 2 days in a week to read those chapters. And when you read, jot down certain points which will be helpful for you to remember or read, go through in the before the examination. Okay, what most often students do mistake.
I've been using UWorld ever since 2020, and it's helped me a lot in being a great exam taker. And
Is that they are in a hurry to write the answer, and when they're in a hurry, they don't read the question properly. And always remember, now even in MD, at the end of the question, they'll put in bracket the marks. It will be 2 + 1 + 2 + 2 something. So that will match the breakdown of the question that you give. So read the question thoroughly, read it 2-3 times, and then look at the marks that is allotted for that part of the question. Mentally prepare your answer and write. Blindly, you see this and start writing, like my friend from King's George said, there'll be no end to writing. Suddenly, you'll remember something, keep on writing. Some of them may be relevant, some of them may not be relevant. So you'll be wasting a lot of time, right? So that read each aspect of the question and marks allotted each component of the questions. So you should be able to understand these terms: enumerate, enlist, discuss, write briefly, evaluate, approach to, and management. So the investigation and treatment. So that's what we have been talking. So let us go through some examples. Okay. The question here, this is a hypothetical question. It's not come in the past, or it might have come, I don't know. Enumerate the life-threatening tachyarrhythmias in childhood. And I have got 2 marks for this, right? Can anybody may take a chance and then try to answer this question? For 2 marks, what will you write? Anybody? You have to be vocal. I don't have patience to read the chat box. Hello.
I think ಯಾರು ಆನ್ಸರ್ ಮಾಡಿಲ್ಲ ಸರ್.
If you're going to sleep, then I'll go home. Shall I go home? Anybody, don't feel shy. This is only a way of understanding how exactly you understand a question. We'll call out Nisha. Who is Nisha? Hello, whose name is visible? I'll ask.
Dr. Devina Singh wants to be unmuted.
Yeah, please. Unmute and then answer. Hello. Can somebody unmute?
Hello, sir. The life-threatening.
Okay. What do you understand by this question? Enumerate the life-threatening tachyarrhythmia.
In enumeration, we just have to write the life-threatening tachyarrhythmias. Like we can list
Ventricular fibrillation.
कि तुम्हारा ज्यादा तुमने एक्साइटमेंट में लिख दिया है 5 मार्क के क्वेश्चन में, वो चेक ही नहीं करेगा, रीड ही नहीं करेगा पहले, तो बोला मैक्सिमम कॉन्सेंट्रेट ऑन टेबल्स एंड फ्लो चार्ट लिखा है, बट
Hello. Hello.
Yes, sir. Hello.
Hello.
Tachyarrhythmia is, you can write the name, like ventricular tachycardia.
Am I muted by chance?
Very
Sir.
Could only one of please answer, like many of you are trying to answer, so it's becoming unclear. Can only one of you please volunteer and answer?
Okay. The host, can you mute everybody? I think I made a mistake by asking. Okay. Now you are.
Sir, ನೀವು unmute ಮಾಡ್ಕೋಬೇಕು sir.
Okay. So this question says enumerate, and I got 2 marks. That means I am expecting to write at least 4. If you write more, no problem. If you write list 4 life-threatening arrhythmias, half marks for each. I'm definitely going to give you 2 marks, right? If you write more, you will not get anything more than 2 marks. You understood, no? Right? So you are ventricular tachycardia, atrial fibrillation, ventricular fibrillation. Then you got pulseless, electromechanical dissociation. So like that, you just write 4. If you can remember more, like any bradyarrhythmia, junctional rhythms.
You just ordered from Myntra. Congrats! You just overpaid. Every Myntra order you place.
You're right. But it should not be less than 4 because the marks allotted here is 2 marks. Then second is, how do you diagnose them? When I write as part of this question, I am asking you to write whatever you have listed, each one of them, you write how you're going to diagnose. That is one way. And because the marks is 4 here, for each one of them, if you write, I will do an ECG, I will do electrophysiologic study, or I will do a Holter monitor. For example, if there's a diagnosis is ventricular premature beats or whatever complicated arrhythmias which come in bursts like SVT, then I may be asking you to do a Holter monitor. So based on what arrhythmias you have listed, I am asking you for each one of them, how do you diagnose them? That is one way. Or in general, you can write, what are the various ways you can diagnose a rhythm disturbance? You can start with an ECG, Holter monitoring, electrophysiologic studies, and so on and so forth. But this is a loaded question. There are 4 marks for this. So your answer has to be good, maybe 1 page. But just because it's 4 marks, don't write 2.5 pages. You must write bulleted points, that's more than enough, right? And the last question is briefly outline their emergency intervention. That means the conditions that you have listed, their emergency measure. So think twice before making the list, because if you've written something which is very complex, junctional rhythm and all, you don't know the treatment. So write the common ones for which you are very comfortable with writing the treatment. So this is how dissecting the question. So this total marks is 4 plus 4, 8 plus 2, 10 marks question, right? DNB students will not get a question like this. Mostly MDs get 10 marks question. So by writing this, you are assured of at least 5 marks because they'll get you some marks for the diagnosis, and definitely for full list, you should get 2 marks. So you get 2 plus 2, 4 and 1 mark somewhere here and there. Emergency management, if you're able to write correctly, maybe another 2 marks. Remember, all MD or DNB students, examiner is most unhappy to give you 10 out of 10. Forget it. As an examiner, I'll be very disappointed if I'm forced to give 7 or 8 marks. So your target is to at least get 5 marks, right? So that is what you should remember, and then write the answer accordingly. Well, give me 2 minutes. I'll connect my power set. Okay, any questions till now? Okay, I'll just show you how this question is answered. When I say enumerate, I'm just going to list. I've written 5 here. 4 is more than enough. Atrial flutter, atrial fibrillation, supraventricular tachycardia, ventricular tachycardia, ventricular fibrillation. How will you diagnose? In this particular key, we are just an overview of all arrhythmia diagnosis. See, important point to diagnose to be mentioned in the following headings. So if you have time, because it is 4 marks question, in the ECG, what do you expect in the ECG? In chest X-ray, maybe you will get a complex cardiac disease, cardiomegaly. What do you expect to get in 2D echo? What are the conditions, indication for Holter monitoring? And of course, treadmill, we don't do it in pediatrics, so leave it up. So electrophysiology. So these are the headings under which you will write at least 2 to 3 lines for each of them, so that you can get 4 marks. Now, management of arrhythmias, you have a nice flow diagram. Instead of writing a full page of a description for each one of them, if I write this flow diagram is all in patch course they gave. So examiner knows he doesn't have to go through each detail, but I know I'm looking for adenosine dose. And then here I would like you to mention the 2 syringe technique fast I'm going to give, and then some drugs and their dosage. So this is an example how you can score 4 marks easily by putting a flow diagram, right? Now, second type of question is describe the advantages and methods of giving kangaroo mother care, right? Enlist the metabolic consequences of hypothermia. This is in 2 parts. The 2 parts are not related, right? And this question came some time back. So here, the question is, I put it in highlight, describe, right? And I have got it in 2 parts, advantages and methods of giving. So I've given 4 marks here. So 2 marks will be for advantages, another 2 marks for method of giving. So easily you can score, you can be assured I'll get definitely 3 marks. The last second part is enlist. I don't have to write long theory answers because the question, the mark is only 2 marks here. So metabolic concept of hypothermia, because it's only 2 marks, if I enlist 4 metabolic consequences of hypothermia, I'll easily get 2 marks. So that is how I read the question, divide into components, look at the marks that have been allotted, and an answer as per marks that is allotted, right? Now, this is how the answer is going to be, right? Here.
This is Willow, and it's a clothing brand for taller Indian women.
Thanks. I want this.
Do you want to know how I built it?
To catch the examiner's attention, benefits of kangaroo mother care, I divide into benefits to baby, benefits to parents, benefits to community, and I go on to elaborate a little bit. And methods of giving, there are different methods. Mother, father position, comfort, baby between mother's bed, abdomen pressing, and baby head turned towards the side, support the baby from bottom, frog leg position. So I have broken down my answers. If you have time, you can elaborate 1 or 2 lines on each of these, right? Then I told you metabolic consequence of hypothermia. I have listed 5, 8, but you don't have to reproduce. If you remember everything, you do it. Because the marks allotted is only 2 marks. If I write 4 of them, definitely I'll get full marks, full 2 marks for this. So in this question, it's very easy to score 6 or 7 marks because 2 straight away for the end list, and the methods of giving straight away I'll get 2 marks, 4 marks. And if I describe and then I describe classifying like this, I'll definitely get 2 marks. So easily I get 6 marks in this. So point I'm emphasizing, even if the question says describe, it's better you describe it under different headings so that your answer gets broken down and the examiner also finds it easy to allot the marks for you. Okay. Next question is, in the long back it has been asked. Classify severity of dengue hemorrhagic fever. It's very straightforward. You have read the WHO guidelines, you just classify it. 3 states are there, but now with warning signs, without warning signs, and describe straight away, you will get easily 3 marks. Write in brief the management of dengue shock syndrome. You just reproduce the WHO algorithm for dengue shock. 7 ml per kg, 5 ml per kg, bolus push, all that you write. And you'll get easily marks, right? I just copied it from the book, but this is how it should be. This is the old classification, but it should be up to date with new classification. So management, like I said, it's partly investigation and partly treatment. So what are investigations you want to do? Hemogram, liver function test, and then the platelet count will include in this thing. And specific investigations you'll write to confirm. Treatment, mainly supportive fluid management. You have to elaborate a bit on this. So that is how you talk about discuss management, right? Now, the most important or most difficult, I'll say, is discuss the approach to the diagnosis of a child present with polyuria polypsa. This is what you do in your clinical medicine, and you should be able to think of all the conditions, what can cause polydipsia, and then write the answer under the following headings. 1 is history, 2nd is examination, 3rd is laboratory. So the approach to a child with polydipsia in history, I'll ask for example, what are the cause of polyuria polydipsia? It may be diabetes insipidus, it may be renal tubular acidosis, it may be diabetes mellitus, it may be psychogenic. So what questions I'll ask for diabetes insipidus? For example, histiocytosis can produce headache, rise ICP, seborrheic dermatitis, or ear discharge, chronic otitis media. Will think that it is diabetes insipidus. Renal tubular acidosis, failure to thrive, metabolic acidosis, rickets-like changes, motor delay, failure to thrive, Fanconi syndrome will be there. So that is for renal tubular acidosis. Then diabetes mellitus, failure to thrive, DKA-like manifestation, and thirst in family history of diabetes. So these are the headings under which I'll answer the question on at history. Physical examination, I'm going to look at the head-to-toe examination. I'll do a thorough CNS examination, and then I'll look for signs of dehydration. I'll see if there's a bladder palpable. Then I'll see for all the seborrheic dermatitis and eczema and things like that. Or I'll see if there's any behavioral psychological problem, adolescent. So like that at history level. Then investigation, you say, I would like to look at the urine specific gravity. I want to measure the urine volume over 24 hours. Then I want to do water deprivation test. How do I interpret water deprivation? So that way I'm able to answer. And this is a broad question. This is an MD question and there's no breakup of marks. That means you have to imagine that they're going to give different marks for different components. So out of 10, 3 marks maybe for history, another 3 marks for maybe for the examination, another 4 marks for the laboratory. So like that you divide. If you want to make it simplified and if you're able to remember an algorithm,
I can teach you code in Python in just 30 days, even if you've never written a single line of code before. How? Simple. In my 30-day Python,
this is difficult to reproduce, but if you remember, you can do like that. That way you'll save time trying to write elaborate essay type of question. So history you ask, then physical examination and CNS examination is what to look at. So this is how you approach. The question that can come for approach is write the approach for a child with a progressive pallor, or write the approach to a child with transfusion-dependent anemias. Write the approach to a child with failure to thrive. Write the approach to a child with refractory congestive cardiac failure. So these are all different questions on approaches, and you should be able to answer these under these headings. That is history, physical examination, and laboratory, and if possible, try and write a flow diagram. Right? Now, the most difficult thing what I find the students is questions related to social pediatrics. This is a googly, and even the best teacher cannot help you. The only way I can tell you guidelines, help you to remember is one, you be aware of all the national programs currently. For example, when I was a PG, that time universal immunization program and expanded program of immunization was in vogue. That's when Indira Gandhi introduced. But now you got so many things on vaccine, right? So you have to look at what is the current. Like, for example, Mission Indradhanush, they say, where they have targeted population. Or you have got IMNCI program. And for some time, it is an ICDS program, it got changed to RCS program and it got to IMNCI. So be familiar with the currently administered national levels programs and state level programs. There are different programs for example, in Karnataka, they have Tottelu Bhagya and things like that. They're locally available programs are there for mother and child. So be familiar with them. They will ask you what are the objectives, what is the target population, and what is the goals for this particular program. So that is one way of addressing social pediatrics. You must know the currently running national and state level social projects that directed towards mother and child. Second thing is, lot of times in common Indian journals or in Western journals, there are editorials. Lot of times editorials will discuss the social issues. For example, if you take New England Journal of Medicine, there's one chapter dedicated to social pediatrics. What is currently in vogue? Like, for example, economic outcome of COVID pandemic, right? Very well discussed in New England Journal of Medicine. So you must be familiar with some common journals like British Medical Journal, New England Journal of Medicine, and for Indians, Indian pediatrics. And if you look at the past 1 or 2 years editorials, lot of times they'll be addressing burning social pediatric issues in these journals. And some of the studies that are related to social pediatrics. So your job is to be familiarized with that. That is number one. Second thing is, at least personally, I feel social pediatrics is one where everybody can be wrong and everybody can be right. More so, the examiner can be wrong and students can be right. So I will use a very crude word that this is one paper where there's a scope for bluffing. It's a crude word. Don't quote me. Don't say that Dr. Subba Rao asked us to bluff. Because what happens when I'm evaluating a paper, I may not be very well aware of what is current. So I'm looking for certain headings and how much you have written. It may be a 10 marks question. And I may say, okay, I'm getting fed up. I'll at least, for having written something, I'll give you 5 marks. One very important message I want to tell all the students, do not leave any questions blank. Because if you don't answer a question, even on social pediatrics, it means I can't give you marks. I'll be forced to give you 0. If you write something, at least I'll give you 2 marks. and 2 or 3 marks can make a lot of difference in between pass and fail. I've had students who got 49 marks out of 100, and for 1 mark they have failed. So don't, if the question is difficult, write something, whatever comes to your mind. Our examiner will have sympathy. For having written something, I will give him a consolation marks. But if you know something, write thoroughly. You'll get full marks. But at any cost, don't leave a question unanswered. That means you're straight away getting 0, and then you'll not get anything. Write something, whatever you know.
Rate my skincare, doc. Skincare में no sunscreen, but skin reaction, breakouts, rashes. Try Himalaya Sun Protect Plus. Jojoba, papaya, wheat germ derived vitamin E जैसे 90% natural origin ingredients. मतलब made in nature's lab. Sun से protect करें, skin को safe रखने में मदद करें. Himalaya Sun Protect Plus.
कोई नया विजय आया है टाउन में?
हाँ, cool star. वो देखो विजय.
तो ये है कूल स्टार इन टाउन। यहाँ टेक्नोलॉजी है कूल, फीचर्स है कूल, इनोवेशन है कूल। Vijay Sales, the cool star in town.
Don't write stupid things like Om Namah Shivaya or Venkatramana Swami or something. I've seen students say, God, please save me. This is my 3rd attempt. They would have written that. Don't write that. Do write something which is relevant and scientific so that examiner will feel sympathy and give you few marks. Right? So that is my take on social pediatrics. Go through the editorials of some of the Indian books. They'll have quoted. Maybe sometimes editorials of newspapers also will address some burning issues in pediatrics. So that is what you should be thorough. Usually social pediatrics is in the 4th paper. So if you've done first 3 papers very well, you can get away with writing something in the 4th paper. And it's very, very difficult to predict what questions will come because the previous year's question paper will contain only social pediatric issues relevant to that. If you look at 10 years, maybe they're on COVID or corona infection. Look at the current. Talk about the how set up a COVID care center, how you respond to pandemic. Administrator, how will you manage your resources? For example, you heard there is an oxygen scarcity. So how will you manage resources? So like that, you can ask any type of question. So look at the recent advances, recent articles, either in journals or in newspapers, and then write down few points. It will be easy for you to help. So finally, answer all questions. Very important. Don't leave any questions unanswered. Divide your time. For example, if you've got 5 marks question in DNB, I'll have 20 questions and I've got 3 hours to answer these 20 questions. So 3 hours divided by 20 questions, you'll roughly know how many minutes you can allot for each question. And if I got 10 minutes allotted, I should be able to write within the next 8 minutes the question and then go to the next question. For example, if you felt that you don't know the answer for a particular question, you can keep it to the last so that if you have time and you get some flash answers, you can write. But I'm told that in DNB, you have to write the answer in the same sequence as the questions are given. But I don't think that is required in MD. You write the question number clearly. You don't have to reproduce the whole question. You write the question number and then go on to answer. You can ask the last question. You can answer first, and first question you answer number 3. It doesn't matter. But you should write the question number very, very clearly so that I can understand what you're reading. Very, very important. Unfortunately, nobody can change it. Your handwriting. The most worst thing that can happen is you written everything, but your handwriting is so horrible that the examiner gets fed up and they'll say, just say, I'll give you only 1 mark for having horribly written. So those who got horrible handwriting, please depend on flow diagrams and pictures to get your marks. Those who got good handwriting will gain, but their problem is with good handwriting, your mistakes get stand out. Examiner will read very, very carefully good handwriting. So it is plus and minus, but try and improve your handwriting. Writing in bulleted text also is not a problem. You don't have to write paragraph after paragraph because I know that in DNB, they do not give any additional seat. In my time, I could make any number of additional sheets. In DNB, and I think it's in MD also, they give you one booklet. All your answers should be answered within that booklet. No additional sheets will be given. So I got time constraints and page constraint. So be very careful in writing things unnecessarily. Read the questions in the first 15 minutes. You dedicate it to read the questions nicely. Mentally make out which one you know answer very easily and which are difficult ones. But the problem is, if you know a question where the answer is very easy, there's a tendency to write lots of pages for that, even though marks is only 3 or 4. So you have to curtail your enthusiasm to write a lot of things. If you know a lot of things, focus your answer, tune to the marks that is allotted. And the difficult questions, you can keep it to the last. But most important, read the question. If this question stem has got some breaks, look at the marks that is allotted and answer to the marks that is allotted. Whenever possible, like we gave an example, try and write classification. Use tables and flow charts. Highlight important aspects of the answer. That's what I told you. And take 10 minutes at the end to go through the answer. You can do it in the last, going through each question. And sometimes if suddenly some thought comes, you may add on a few lines. And very important, keep the last half an hour for revision. You have to revise.
In medicine, seconds matter. But finding accurate, life-saving information isn't easy. That's why we built the
in the examination. But here what revision I've told you is in the preparation, revision of topics which are really important. And if you have still a lot of time and friends, maybe you can do, now you got WhatsApp, you can do a WhatsApp chat and say, I didn't get the answer for this question, can you find out? And if you got a good teacher who can help you out, you can even ask, I don't know the answer for this, how do you answer this? And that's how the teachers will be useful to you. So with that, I think we have spent more than 1 hour. I can stop sharing it. If you got any specific questions, I can answer you. And I hope I have given you an overview of how you approach a theory paper. Any questions?
Sunil, you can stop the video and
answer on behalf.
We'll open the floor for.
You can answer on behalf of your students if they have any doubts.
Stop sharing the video. I'm sorry, it was a pre-recorded one. Sorry for the in-between advertisements, but I think I have conveyed whatever was there to be conveyed. So if there is any questions, particularly you want me to answer, I'll do that before I go to the second half. Even the examiners can also ask. Sunil and Rajendra or Chandrasekhar, you are most welcome to ask.
No, sir, it was quite apt for all the postgraduates, I think. Only thing, some universities have different pattern of asking exam that social pediatrics in the last paper or such things can change, sir. That's all.
Yeah, there's a question on give tips on time management. See, time management for two things. One, is it for the preparation for the exam or time management for writing the answer? You clarify which one you want.
Maybe writing the exam, sir.
I think I told already. If you are writing the answers, see, remember, if you're DNB or even MD is 10 marks, is it now or 5 marks?
10 marks.
I'm not sure.
10 marks.
Okay. So if you're MD student, 10 marks, 100 marks question. That means you'll have 10 questions. And you are given 3 hours for writing that answer. You leave off first 15 minutes for reading the question and last half an hour for revising. So that leaves you roughly 2 hours, 15 minutes or 2 hours, 30 minutes. So roughly 10 divided 2 hours, that is 60 minutes divided by 10, or 6 to 7 minutes per question you will get. So even then, the answers you know very well, you will finish it fast. So give that surplus time for answering the difficult ones. That's how I do. So point I'm trying to tell you is first 15 minutes after you receive the question paper, read the question thoroughly, understand the question, and mentally form a framework. So first 15 minutes gone, start writing the answer. Make sure that you don't exceed 6 or 7 minutes per question. If it's a 10 marks question. If it's a 5 mark question, 3 to 3.5 minutes per question. But definitely give room for half an hour for revising. Maybe you have left out some points. You may add on some points. That's how you manage your time. Did I answer your question? Hello?
Yes, sir. That documented, yes, sir.
Any other question? Okay, I just want to ask you, all of you are appearing for the theory exam? One of you can respond, or some of you have just come here to learn.
They are
All are exam going?
no, sir. Some of them are first year, second year PGs also.
Okay. So the second question, what in the last session also they asked, how does a student prepare for learning from first year to final year? How do you allot time? And that's a very important question because for fresh PGs, first 3 months is all about running around for thesis topic selection and meeting your guide and all that. And then in the next 3 months, you have to submit your synopsis because your thesis selection or not depends on the synopsis submitted. And you should remember that once the thesis is submitted and synopsis is accepted, you can't change the title halfway through. That will be a problem. Keep your guide in good books. So first 6 months, you'll be running around for this. In the next 1 year, you divide your time into reading the standard textbooks. Every day, out of 24 hours, 8 hours you sleep, 8 hours you have ward work and other things. So you'll have roughly about 4 to 5 hours leaving off lunch and relaxation. So you must allot time for reading. So in that 4 hours, what I say is 1 hour should be dedicated to systematically reading from chapter 1 to chapter last. That should go background. The second hour should be related to what seminar is going to come next week. Those topics I'll read. The third hour, I'll look for difficult topics. And once a week on Sundays, I'll read one or two journals for recent articles. And that's how I revise. And in the last 6 months of your 3-year career, there'll be a lot of running around for thesis, binding, printing, getting the examiner signature. You will not have one bit of time to read. So in 3 years course, let us say a course starts in January. The third year, January to June, you will not get any time to read because you'll just be running around, getting thesis printed, correction, proofreading, and boss says this is not all right, you write again. All that headache will be there. So last year's first 6 months, you cannot read. So your best time to consolidate your reading is in the first 1.5 years. Leaving off the first 6 months for thesis, 1.5 years up to second year, end of second year. And then again, last 6 months when you're nearing the exam from June to December, it is revising and answering theory paper. So that is how you divide your time. And in between, you have got cultural activities. You have to go to your home for some function. So all that you have to give margin and then plan accordingly. You don't leave anything to a chance. That's what I would advise all my students. You can never read pediatrics in the last 2 months of study leave. A lot of students say that, oh, anyway, we will get study leave, we will read. No, you can't. You are reading start from first year and goes through consolidate in second year. And the third year is mainly for revision and then catching up with the previous year question paper. Okay. Okay. Now, my second half, I finished 1 hour. Second half is to answer some question related to practicals. Do you think necessary or let the students digest only this much?
No, sir. Please tell, sir. Continue, sir.
You ask them. Let them vote. Raise your hands if you want the discussion on long case, on CNS. You can raise it on your chat box. If I don't see an answer, I will close the session. Hello? Because theory paper writing student may not be worried about practicals right now. They may say, let us digest this much.
Actually, sir, practical is very much required for the students.
Okay.
Though theory, actually nowadays, there are a lot of books are there and even social media or such online lecture they are listening. But practical skills, I think students, they require multiple listening and
So technically, you're saying we have wasted 1 hour of time.
No, sir. Theory definitely, sir. Having knowledge is one thing, and executing that knowledge is other thing. And with your class, I think you definitely we got to know that how to write in the theory exam. That is equally important because we do see
What I have
even
tried to
brilliant.
do is I have looked at the question paper from the examiner's point of view and tried
Yes,
to
sir.
give some of the insight tips. I hope that will be
Yes,
useful.
yes, sir, definitely helpful because such lectures we rarely get to see. Though we see commonly, speakers taking classes on their areas of specialty, but such common topic, I think they are the one which are really required, especially during the exam time because we have seen even brilliant students they may not be able to answer well because that answer structure may not be proper and they may not be able to prepare well or to give the time properly. So I think your class definitely it would help them to write properly, and not only the brilliant students and the average one also could write the answer well, and I think they could also score well. So I think definitely such classes are required, especially during the preparation time. So in that way, it's definitely helpful, sir.
Okay, thanks, Rajendra. I see a lot of hands which are raised for practical examination. So I'll just tell orally briefly what is expected what to expect in a practical examination. And I'm sure, like I asked in the conference, all of them find a CNS case the most difficult to face in the examination. And I'll try to answer some of the difficulties what they face. But before that, I can answer for pediatrics. I'm sure even in DNB I can answer. But I'm sure even in MD now OSCE has come. Now, what you should understand is the whole DNB now, because of post-COVID, it is compressed to 1 day's examination. In that 1 day's examination, first 2 hours you have got what is called OSCE, where there are 30 stations and you get 150 marks for the OSCE. It is added to your theory. It's added to your practicals. And then from 9 o'clock to 3 o'clock, you will have what we call 2 cases. We call it semi-long cases. Unlike in the MD where they have 1 long case and 2 short cases, in DNB we got something which is neither long case nor short case. So that means you're expected to present it like more or less like a long case. So that is the pattern. And currently, post-COVID, after 3 o'clock, they have introduced 4 areas, what is called a pediatric grand rounds, then vaccination, then emergency medicine, and neonatal and PALS stations. So and instruments also may be kept. So that is the whole pattern of the practical exam in DNB. MD, I think they still have 1 long case and 2 short cases, and in the afternoon there's a Viva. Am I correct, Rajendra and Sunil?
Yes, sir. ASCII also has started, sir.
ASCII is also there.
Sir.
Okay. So more or less in the same pattern. Now, what you should do, those who are worried about practicals, how they should prepare. Number one, the first years and second years, as many times as you get opportunity to present the cases in the ward, you should take, because that is where your confidence building happens. The more fluently you present the case in your day-to-day practice, you will have more fluency in the examination. That is the first tip. Second tip I'm going to give you is, when we allot a case in the practical examination to the student, the time allotted for the student to examine a given case is only 30 minutes. Rarely 40 minutes. 30 minutes is standard. So in that 30 minutes, you are supposed to take a good history, supposed to take a good, proper clinical examination, and come to some kind of conclusion. Here is what I want to give advice to all the PGs preparing, that in the examination, as an examiner, I'm not bothered whether you can get the correct diagnosis. Whether it is JAA or SLE, or it doesn't matter. What I'm saying is, the child has come with PO, joint pain. How will you differentiate it from rheumatic fever, rheumatoid arthritis, or SLE? So I would like the approach more than the accurate diagnosis. Even if your diagnosis is wrong, doesn't matter as long as the approach is correct. So don't break your head about making a very correct, accurate diagnosis. You just have to get the approach correctly. That's very, very important. And to that extent, a good history is what is very, very, very crucial. Now, when we take history, either in the ward or in the examination, lot of times, even in the day before yesterday in the conference, I point out to the student that they think that telling the history is exactly translating what the mother told. And mother in her worry will tell, I went to this doctor, they gave this injection, I went to that doctor, I was admitted for all that unnecessary, irrelevant things. All that could be summarized into this child had problems since 8 months and had multiple hospital admissions for whatever problems. And focus on the disease progression. How did the disease start? How did it progress? Did it have complications? So I tell all the PGs that when you're taking proper approach will be, your history should answer 3 major questions. 1, what is the problem? Second, where is the problem? Third, what else is the problem? If you have to reverse the order, first I have to ask, where is the problem? That is, where is the anatomical localization? For example, if it's a respiratory case, I'm not just happy it's a respiratory case. I must say it's upper respiratory, lower respiratory, parenchyma, pleura, or middle ear. So anatomic localization by history will be very, very important. Then we look at the etiology. Is it viral, bacterial, fungal, immunological, connective tissue? So you ask questions related to that. Then if it's a pneumonia patient, you could land up with a complication like a pneumothorax or a empyema. So you ask a few questions for the common. Or for example, if there's a diarrhea, malnutrition patient, you ask questions for complications. So whenever you take the history, make sure your history answers these 3 questions and not carried away by what the parents keep on saying that I went there, I went there, this injection again. That student, I'm sorry, I should say, that patient was present in the conference. The child had a very prolonged NICU stay. And half of his history is sent on saying he was in a big machine first, then he was in a small machine first, then after small machine, he was put on a tube first. It is not necessary. No, who cares whether big machines? All you have to say is he was on assisted ventilation. You will not fail for saying he was on ventilator. So why you should go on round about describing what machine, how many nurses stood by the patient? No, not relevant. So that you should remember that 30 minutes time is there. And within that, you have to take the relevant history and try to suppress the mother from telling unnecessary history. That's very, very important for you to answer. And also in the examination, in practicals, we don't expect you to write the whole case history. That will take a lot of time. You will note down only the points that you may forget, like anthropometry you may forget or blood pressure you may forget. So write down those, or some points in the history if the mother has told you will forget. So write only those, and because there's no marks given for the history that is written in a case. Even though you give you a case booklet, there's no need for you to write down everything, right? Maybe you want to write down a pedigree chart, that is important. But everything apparently, well, all that in text, if you write, it will take lots and lots of time. So that is as far as the preparedness for the cases is concerned. Now, in the examination, when as an examiner, in a day, I'm expected to see 10 students. And I'll have limited time because I may have to go for my evening flight or something like that. I have to assess and give you marks within 10 or 15 minutes for your history. So here, like I told in theory, it is necessary for you to catch the attention of the examiner that what your approach, what you're thinking, what your knowledge is. So be fluent in what you're telling. Don't get confused and present fluently. Any PG whose history is presented without examiner interrupting, suddenly there's a stop here, stop there, then you have done your job. History, if it's presented fluently, then completely you have passed the exam almost. And remember, each system, the examiner asks you to demonstrate at least 2 or 3 signs. For example, it is respiratory. I'm asking you localized apical impulse. I'm asking you localized trachea. I'll ask you percuss the chest. If the CNS, I may ask you power of the limb or tone of the limb. If the CVS, I'll ask you apical impulse, fluid thrill, right? Like that, 2 or 3 points in physical examination, you must be thorough like it is given in the textbook Hutchison or whatever practical you're doing. If you're not able to demonstrate, it's a very, very bad impression on the examiner. So by demonstrating properly, and very often what I found in the examination, I rarely come up to asking you management and differential diagnosis. Most of my time asking the student is followed by correcting your questioning your history and examination. If you know very well and the question examiner asks you recent advances and management, that means you have done very well and you're a gold medal candidate. So when the examiner asks you lot of questions, it can mean 2 things. Lot of questions means you have done very badly, I want to pass you. Lot of question means you have done very well, I want to give a gold medal. Right? Very often students get confused that the examiner is asking me recent advance, I don't know. He's asking recent advance only because he wants to give you extra marks. An ordinary average student like me was never asked recent advances. So if you are asked about recent advance, what happened in this journal, then be sure you have done very well in asking you for give you more marks. So don't get put off by that. Don't get put off by the appearance of the examiner. There are two types of examiner. One type of examiner, like me, very aggressive, very tough, very loud. I will not be satisfied till my PG cries. But when I mark, I give very liberal marks. There's another set of examiners. So, oh, very good, very good, very good, very good. And they'll give you every very good means they'll give you -1 marks, -1. So if the examiner is telling very good shabash, beware that he'll give you less marks. If the examiner is aggressive, he's trying to check your potential and try to give you maximum marks. So that is the examiner's tip I'm going to give. Now, what you should do while you are waiting for the practical examination is make a mental list of what all cases can be kept and read them in the textbooks. For example, they can keep a VSD, they can keep a phallostetology, they can keep a child with a hepatosplenomegaly, they can keep a bronchiectasis patient, or they can keep a pleural effusion patient. Or in a CNS, always they'll keep a developmental delay. They may keep a stroke patient, or they may keep a regression of milestone. So about 10 cases and read about them thoroughly. Then your practicals is almost done. Right? Now I have got a PowerPoint presentation on how to present a case in a development delay patient and how to present a case in a non-development delay, non-cerebral palsy patient. So we'll run through these slides, and at the end of that, if you have any questions, we can ask. I'll share my slides, Sunil.
Yes, sir. Yes, sir. Sure, sir.
Tell me if it is visible. Is it visible?
It's coming, sir. It's visible, sir. It will make it
visible?
full slides. Yes, sir. Visible, sir. Full slide, sir.
I'll do that. Wait. A full slide ಬರ್ತಾ ಇಲ್ಲ. Yes.
It stopped sharing, sir.
One second, I'll share.
Yes.
Visible now?
It's visible, sir, but it's still showing.
Now? Full
It's
screen is visible?
Yes, sir. Yes, sir. It's there, sir.
Okay. So, as far as CNS, I'm audible now?
Yes, sir. Yes, sir. Sure, sir.
Okay. As far as CNS long case is concerned, be sure that all of you will get this developmental delay, cerebral palsy, proper infant. So you must be thorough on how to present a child with developmental delay. The second set of questions, just hold on for 1 second, I'll answer it. Hello. One ನಿಮಿಷ ಕ್ಲಾಸ್ ಉಂಟಾನೆ ಇಲ್ಲ 1 ನಿಮಿಷ ಇರಿ. So how do we take, so what I told is that all of you be prepared to face a long case of development delay. There's no doubt you will get it. And lot of students make mistake in presenting history in a development that I'm going to elaborate. But you may get TBM, GB syndrome, that also you may get, depending on the center that you're all with. But if your luck is bad, maybe you'll get a post-MSAT reticulate or sometimes hydrocephalus, chromosomal abnormalities you may get. Sometimes you may get Wilson disease, neuro. So these are not so common, but the approach will be the same. So be prepared for those which are highlighted in red. Be also prepared for this in a long case. Now, how do we take history in a cerebral palsy patient? Now, What you should remember is very often, I know the teachers also tell you, and some of the students also present, but I have got my personal observation that just because the child has got development delay, student says, now I want to start from antenatal history. What you should remember is when the child comes with developmental delay, that is the presenting complaint. So your history of presenting illness is development delay. And why you are telling that is we are answering question of where is the problem, what is the problem, what else is the problem. So if you answer where is the problem, I know that I'm looking at a cortical lesion or a subcortical lesion or a hypothalamic lesion or a internal capsule lesion or a brainstem lesion. So only by asking localizing, for example, in the patients you have presented, the child had a lot of abnormal movements. I know it's a brain basal ganglia involvement. If a child has got convulsions, I know it's a cortical. So your presenting complaint is development delay. So your history should start from history of presenting illness. However, since all of you have been taught to start with antenatal history, you start, but why are we starting with antenatal history? Again, to localize, to answer what is the problem. Antenatal history will tell you the etiology, it will not tell you localization. So that is very, very important. So what is the point that you should not forget in a child with development delay? So like I told, most of them present a delayed motor milestones, so that becomes your presenting complaint. And I will always ask the mother, when do you think the child was perfectly all right? An educated mother may say it did not fix the vision, but a relatively less educated may think child is doing very well. And then on 9th or 10th month, when she sees other children, they may find it is delayed. So mother may say it is all right till 9 months and then she noticed. So be very careful, when did the mother notice? Because the earlier the onset of development delay, the more chance of global delay. The later, then you have got focus area. So delayed milestones is more important. And tone, very often the mother will say child is not moving the legs normally. Tone is an important feature. Sometimes it means spasticity, hyperreflexia. And you must ask for hand preference, whether it's because if it's one hand preference, then it means it could be a hemiplegic in this thing. Lot of these children growth means development delay will have either obesity because of inactivity or they'll have growth delay. So that could be growth failure could be there. Very important for you to look at and ask for history of persistent neonatal reflexes. We'll elaborate that. And presence of pathological reflexes also should remember. And you should remember that clinical manifestation will change with maturation. So these are some of the general manifestations of cerebral palsy. Also, you should remember in any CNS case, onset and progression. Is it a static encephalopathy or is it progressing? That's what you should remember. Now, I will emphasize any number of times that if a child got development delay, that becomes your presenting illness. That also becomes your higher mental function. That is, remember. Very important for you to note the age of onset. Less than 6 months, if the delay, the mother has noticed no head control, no visual fixation, not hearing, that means insult has been perinatal or antenatal. So your focus should be there. But if the delay has been much later, for example, a child developed meningitis and then had arrest of milestones. Till 1.5 years, child was all right. After that, the milestones are arrested. So the problem starts at 1.5 years and not from antenatal. That's what you should remember. And to say whether it is global development delay or any particular domain, you should know which domain is affected. There's only pure motor, or pure mental, social, language. For example, if you've got a patient with autism, there may be just only language development. So it is very important for you to say which domain is affected and how is it progressing. Has it remained same or has it progressed? And this is a very important question because when you have a child with development delay, you must answer question number 1, is it delay? Number 2, is it arrest? Number 3, is it regression? Because the etiology will totally differ if it is delay versus arrest versus regression. For example, if it is delay, it could be anoxic damage, hypoxic damage. If it is arrest, it could be post-meningic or post-encephalitic sequelae. If it is regression, you may have all the neurodegenerative disorders. So etiology will differ and management also. So you must decide whether you are dealing with the arrest, delay or
regression. Lot of cerebral palsy patients may have stroke-like symptoms, so hand preference will tell you this eye is not moving one, or an incomplete moro. That will also tell you this is stroke-like. Abnormal movements, choreoarticular movements or tremors will tell you that this child has got basal gang. For example, you've got a condition called infantile tremor syndrome, where they have Parkinsonian-like tremors, like it is due to B12 deficiency or copper deficiency. That will tell you the basal ganglia is affected. So presenting complaint becomes very, very important. And mother may tell you, all of you are used to telling mother was finding it difficult to wear the diapers, it was slipping through the hands. So it will give you a clear-cut idea whether the child is hypertonic or hypotonic. Now, lot of students talk about in history cranial nerve deficits. Yes, it is important, but in a childhood development delay, auditory and visual are two important things that will help you to localize. So vision and hearing is very important. How is the behavior of the child? This hyperactive acoustic features. And if there are endocrine problems, all of you are very familiar with how hypothyroidism presents: hoarse voice, coarse tongue, delayed development, thick skin. So it's a preventable cause of mental. Or for example, galactosemia, you may have a child with jaundice and refractory seizures. That will give a clue. And currently, in our days, whenever a child had developed delay, we always used to label it as cerebral palsy. But we know that now with our recent advances in investigation available, at least 30 to 40% of those patients whom we labeled as cerebral palsy are turning out to be inborn error of metabolism. Why I'm telling this is, inborn error of metabolism, at least some of them currently are treatable. So you must take, history taking IEM is very, very, very vague, but there are some patterns: failure to thrive, repeated child deaths, or color and odor of urine, recurrent seizures, waxing and waning, family history of deaths. So all these subtle symptoms which can make you think of IEMs or acidotic breathing, early neonatal, all these symptoms. So in a childhood development delay, spend some time at least into making sure that you have taken history for inborn error of metabolism. Institutional child, of course, it is also one of the cause of delay. When did the seizure start? Did it start early? That tells you it's cortical. So when we localize, it's a cortex, subcortex, internal capsule, basal ganglia. With seizure, it tells you it's predominantly cortical. If it's a hemiplegic, it's internal capsule. If it's tremors and more, this thing. So what I'm trying to tell you is, we are trying to answer the question of where is the problem by the symptom. So that is what you have to ask for. And when you tell your negative history, by telling no history of seizures, I'm trying to tell the examiner that probably this is not cortical. Also, if the child with neuroregression, history also will be able to tell you whether it's a white matter disease or a gray matter disease, or there's an overlap. So that is how you put headings on the history of presenting complaint to ensure where is the problem. To ask what is the problem, of course, you have antenatal history where you ask for intrauterine infections, chronic maternal infections, chronic maternal medications, or chromosomal disorders, or history of birth asphyxia. That will tell you hypoxic insult, or dysmorphic features. It will tell you it is a chromosomal disorder. So history will tell you where is the problem. History also should be able to tell you what is the problem. When you examine, you look at the activities of physical growth, activities of daily living, and if there's any feeding difficulty leading to failure to thrive. Very often we forget past history, so we ask for past history of recurrent seizures, recurrent vomiting, failure to thrive, and fever with convulsions or altered sensorium, post-meningitic sequelae. So past history is very, very important. Number of hospital admissions, why was it admitted? It will give a clue. Now, very important for us to, important is, very often PGs tell, now coming to antenatal history, and most of the antenatal history, I get what is an obstetric oriented. They'll say para 2, the Gavda 3, whatever, and was booked pregnancy. I attended antenatal checkup, multiple, this thing was done, and she did not have it. All that what an OBG PG has to take, you will tell. But from my point of view, in a childhood development delay, there are 5 very important points what you have to take in prenatal and antenatal history. 1, consanguineous marriage. Number 2, any children with dysmorphism and chromosomal abnormalities. Any early neonatal or pediatric deaths, any abortions or stillbirths. That is prenatal. Then intranatal, you ask for intranatal infections in the way you know how to ask, fever with rash or recurrent abortions or whatever. Chronic maternal diseases like SLE or a rheumatic fever or any other chronic conditions or malignancy for which the mother is taking. And specifically, if you open the book, there are certain drugs which can interfere with the fetal CNS growth, like fetal alcohol syndrome, fragile X syndrome, or phenytoin. So you must specifically ask for these. Generally, students say no history of drug intake in the mother without knowing what drug you are asking. So make a list of what drugs the mother is taking, which can affect the fetal growth. So a good pediatric-oriented antenatal history should cover these points. And very often perinatal history, you ask for birth asphyxia and they say child cried well or did not cry well at birth. Yes, it is a good thing what the mother can remember. But remember nowadays, most of the deliveries are by cesarean. And if you ask the mother, did the child cried well after birth? She says, I don't know. I was under anesthesia. So you will have no information. You have doubt. So what I tell all my PGs is to look for what is called surrogate markers for birth asphyxia. Of course, you ask in the neonatal, more preterm the baby, more chance of development delay, more low birth weight, more chance. Sometimes it will be combined. Mode of presentation, mode of delivery, all this can have an influence on perinatal asphyxia. Meconium site aspiration is also very important because they can get severe hypoxia. So I call what is known as surrogate markers for asphyxia. Yes, you ask for immediately cried after birth, but you look at this list, all this will tell you possibly there is a perinatal or a intranatal insult. So don't just stop by asking cried after birth. Make sure you ask for surrogate markers for birth asphyxia, perinatal hypoxia, before you make a conclusion. Of course, maternal age and paternal age is very important for chromosomal disorders. Consequently, I already told you, and other family members with development delay. If it's a single parent child, multiple languages, all this can lead to some kind of development delay. Ask definitely for birth weight. For example, today I read in paper, some child, 550 grams child was saved in OM hospital. It had a 78 day in the NICU. I can make a fair guess how much of insult this child's mental status should have suffered. So birth weight and gestation is very, very important. Respiratory distress at birth tells you that it could be meconium aspiration or highly membrane. Very important. All of you ask for jaundice, kernicterus, we know is a very important for delay. Early onset neonatal seizures will also give a clue that it could be perinatal hypoxia. Feeding difficulties, prolonged NICU stay. And lastly, you look at the socioeconomic status. Because poor patient means they can't reach the hospital, home deliveries, long distance to reach the hospital, and all other consequences of harm. So in brief, if you get a cerebral palsy patient, what history that you should ask? One, I must ask, where is the problem? When I say where, is it cortex, subcortical lesion, internal capsule, basal ganglion, cerebellum? Number two, I want to ask whether it is early perinatal insult, which could lead to global delay, or a postnatal insult, which could be developing specific language or seizure disorder like that. So focus completely on answering these questions rather than telling all kinds of stories of where the mother went, what the mother did, and all that is not relevant. It may be good when you're presenting in a ward rounds, but in the examination with time constraints, I don't want you to tell a lot of unnecessary, unwanted things. Now, just to brief you, if you get a cerebral palsy patient, there are five types of cerebral palsy, the monoplegic variety, the hemiplegic variety, the tetraplegia and quadriplegia. Why it's important is, like I've shown in this diagram, each one has got one particular area of the brain that is affected. Hemiplegia may be internal capsule or cortical lesion, whereas the ataxic variety may be brainstem or cerebellum. So characterizing what is the type of cerebral palsy will be able to tell you whether it is spastic, dyskinetic, or ataxic type of cerebral palsy. Now, what are the characters of spastic? Early hand preference, difficulty using affected hand,
growth arrest and facial involvement is rare, circumduction of gait in a bigger child, and spasticity, upper motor neuron signs, and refractory seizures. Those are the diagrammatic representation of a spastic cerebral palsy. Then you can have spastic diplegia, which most often seen in preterm infants, bilateral leg involvement, and commonly may have some degree of arm impairment. Most often they are asymmetric development and generally have upper limb tone very floppy, but lower limb scissoring will be there. That's what you look at when you do 180-degree examination. As the child grows, you may start seeing toe walking, and spasticity of hip muscles may lead to femoral subluxation. And hyperreflexia, ankle clonus, they all will be present in spastic diplegia. Spastic quadriplegia, it's generally a white matter damage, commonly seen in periventricular leukomalacia. It's due to abnormal brain development or intracranial hemorrhage, or it could also be due to HIE, kernicterus. All this can cause spastic quadriplegia. Presentation, generalized increased muscle tone, legs involved more than the arms, decreased limb movements, difficulties in swallowing and predisposition to aspiration pneumonia, spasticity, signs of human involvement, right? Spasticity of hip muscles may lead to femoral subluxation, flexion contraction of the elbows and wrists. Visual and hearing impairment may be more common in spastic quadriplegic children. Learning intellectual disabilities are also more common, and they have seizures. Why I'm telling this is, if you get a cerebral palsy in the examination, the examiner will definitely ask you what type of cerebral palsy it is. You must be sure whether it is spastic, diplegic, quadriplegic, or a mixed or ataxic, and justify. Sometimes there may be an overlap of symptoms, but at least you should make an attempt to classify and try and tell where is the problem. Now, another important thing is in a childhood development delay, the milestones. You must be able to tell whether milestones appeared on time and they disappear on time, because in a childhood development delay, persistent or primitive reflex is an important clue for the degree of insult. And the last category is the dyskinetic cerebral palsy, extrapyramidal signs, choreothyroid movement, and abnormal posture. All this will be seen in dyskinetic. And it's an uncommon form of cerebral palsy. So what I'm trying to tell you is, yes, how to take history in a patient with cerebral palsy. Personally, if I am the examiner, you now want to start the antenatal history, I get very upset. But I know a lot of examiners want you to start with antenatal history. Do that. But antenatal history should be focused on trying to tell when the insult occurred, what is the insult, and not taking an obstetric-oriented history. You take a pediatric-oriented history. That's what I tell all my PGs. So once you take a proper history, in the examination of a child with cerebral palsy, there are two things which the examiner asks you to demonstrate. One, if the head circumference is abnormal, measure it and tell. Second, any dysmorphic features you describe. And if it's a long-standing cerebral palsy, look for contractures and callosities at pressure source. You must be able to tell that. But when it comes to CNS examination, I may ask you to demonstrate power. I may ask you to demonstrate tone. Now here, very importantly, during your training, I don't know whether somebody has taught you or not, the examination of power in a cerebral palsy patient is difficult to go systematically. So you tell what is called the best observed power. If the child is lifting the hand and say moving around, then you say best observed power is 3+. If the child is not at all moving the limbs like a floppy infant, you say best observed power is 1 or 0. And you cannot do the individual group of muscles as we do in other patients. The other important thing is they'll ask you to demonstrate tone. And tone in a child with cerebral palsy that is less than 2 years, there's only 2 ways of demonstrating tone. One is what is called as 180-degree flip. You will see in the YouTube and you can see it in the ward also. And second thing is what is called Emil-Thiessen angles. So if somebody asks you to demonstrate tone in a child with cerebral palsy, do either with a bigger child, you do the conventional method of flexing the limbs and all that. But in a smaller child, always remember, do practice 180-degree flip and Emil-Thiessen angles under interpretation. The more spastic the child, the more rigid will be the Emil-Thiessen angle. More hypotonic, more flaccid. Your popliteal angle, adduction angle, all this will be exaggerated. So I can't teach you in this session, but you should go back to your ward and practice these angles and
180-degree flip. And that's all I'm going to ask you. And if after all this I have time, then I'll ask you how do you manage. Then you say multidisciplinary approach and pediatrician, development specialist, and neurologist, psychiatrist, and social worker. All that will come, but very often we don't have time to ask those questions. But you should be knowing very well. If you are doing very well, then I'll ask you these questions. So I'll stop here for a few seconds and ask you if there's any particular doubt you have as far as history taking in a cerebral palsy. Hello. Sunil Sakenappa.
We'll ask that.
Because there is another 1 hour of discussion on history taking in a non-cerebral palsy patient. That I think which time is, we already come to 4 o'clock. I don't
Yes,
think
sir.
we have time for that.
Yes, sir.
I can take questions both for theory question, theory answer, and history taking, because if you are very thorough with cerebral palsy, I think you have passed your exam. I guess there are no questions.
Yes, sir. They have not. If anybody has any questions, please raise your hands. You can directly ask sir, or you can type in the chat box.
Yes, sir. History taking in this developmental delay definitely challenging, because as you are rightly highlighted that most of the examiner are having different opinions. Like a few may prefer to go from the, especially the presenting illness. A few may prefer to go from the antenatal, and few may prefer from the start of the symptoms. So I think that you have rightly highlighted the point. But I feel definitely the students, they require a practice of presenting so that they will get to know, because I do see students struggling, especially in the case of developmental delay children, presenting the history properly. And rather than asking questions, which you are rightly said to that antenatal, even they present antenatal, that should highlight mainly the insult, towards the insult, like the time of insult and type of insult. The history goes more towards the obstetric points of view. I think that shouldn't happen. I think definitely that is learning point, which I think the rightly point. I think all of as a participant will take it.
Yeah. Any other doubts?
Yes, sir. As you told very aptly, sir, like if they keep on telling antenatal, that history, this history, it looks like they are beating around the bush. They are not coming to the main point. So usually, if they don't know, they start doing. So please avoid doing such things. That is very important.
Sir, actually, what is my observation from students' point of view? The students, they are usually comfortable in presenting the history from the antenatal, because they are comparatively perfect, because they are prepared for neonatology and even for the general pediatrics, because usually they present antenatal history in neonatology. So that's why also students,
I agree that they want to start from antenatal. Examiner is also happy. But an antenatal history should be answering the etiology and not just say book case, this, that.
Yes,
So
yes,
5
that
points you
should.
should tell in antenatal history. That's it. So what I tell my PGs is, if you think the development delay mother has noticed very early, then start with antenatal history. But if the development delay they notice at 1.5 years, there's no point in starting at antenatal history.
Yes, sir.
Correct.
Yes, sir. Few of the questions have been asked in the chat box, sir. First question is, can sir please share the PPT on the when students have asked
Okay, we'll share. We'll share.
Another
Yes.
Another question is book for practical exams.
There's no book, Dr. Subba Rao.
Yes, thank you.
No
Sir.
book. When I write a book, I'll tell you.
Yes, sir. Okay. I think that it requires a persistent practice and listening to the experts who have been in this practical pediatrics. And apart from, definitely there are books, but definitely it requires practice, I feel, because exams are skill oriented rather than theoretical oriented. So you need persistent practice both for examination and listening to the examiner.
See, the other point I'm trying to tell the students is, in the practical examination, we are trying to assess whether you have actively participated in your day-to-day
word activities like presenting a case. If you have done that regularly, then you will be doing fluently. Very often, a cerebral palsy comes, you just say, refer to physiotherapy, and you don't even bother to take history. And you'll be seeing the patient for the first time in the examination. That's why you are nervous. So, message is those are second years, don't ignore the cerebral palsy patient. They also need a good examination. Go pay attention, take history, and make notes. That's very important. Another question I have got here is, if we explain development in HPI, should we tell development? So what I'm trying to tell you is the headings of history of presenting illness, past history, nutrition history, we have done it for our convenience, so that we will not forget. But in a given case, we are always trying to reshuffle the order. In a child with developmental delay, the developmental milestones become the, instead of presenting and now coming to development milestone, you present as, and there's no need to repeat it during developmental milestone. Right? It is just rearranging the order. Like you have rightly or wrongly, decide to start antenatal history first. But conventionally, we have said antenatal history should come late. So you are permitted to modify that. You modify this also. The development delay becomes a presenting complete. So no need to repeat the same thing in developmental milestones. Everything will come there in presenting illness.
Another question is, sir, how about Babinski comment as per age?
What is this?
Babinski sign, how to comment as per age, especially in infant.
This you have to come to me and face my examination. Up to what age is Babinski positive and when does it disappear? That's on the primitive reflexes. Okay. So what you should know is, once the child's walking, the Babinski should disappear. So any Babinski positive beyond 1 year, once child starts walking, is an abnormal. It's an upper motor neuron sign. It is not a sign in a child less than 1 year because child has not yet started walking. That's a fundamental difference how you interpret Babinski. But Babinski alone should not be taken. It should be taken in this thing with other long track signs like spasticity, hyperreflexia, and then you look for Babinski. Does it answer the question?
Yes, sir. I think you have perfectly answered the question, sir. Yes. And sir, another question is, sir, could you advise on approach to asking DNB?
Okay, Sunil.
Yes, sir.
One more session. ASCII
Yes,
will
sir.
take another.
We'll
We
arrange
have
that.
to orient and do one mock ASCII because it is difficult for me to tell ASCII.
Yes, sir. We'll arrange, sir. We'll
ASCII.
plan, sir.
You can do that, or if somebody is interested, I think one Mangalore session has got 2 hours mock ASCII which I'm conducting. Otherwise, Sunil will take care, and then one Sunday he will dedicate it to mock ASCII with answering questions.
Sure, sir. We'll plan, sir.
You can choose a faculty of your choice.
Yes, sir. After today's class, actually, we are feeling to, apart from listening to you this online, we definitely would want to see your expertise in the clinical case presentation, sir, which we usually have every month, third weekly Sunday. I think that time definitely, I think the developmental delay case will be continuation of this session, sir.
It will be repetition. I won't give anything new.
Yes, sir, but few of the exam skills, especially examination, which you told 180-degree flip and other examination, I think definitely it would help to students, because students, they definitely lag when it comes to the examination, because that is individualized, especially in infants. It cannot be a simple exam, because higher functions, they may not be able to assess properly in infant, and assessment of tone power, it is a tricky over there. I think definitely, I think those skills definitely, because apart from knowing, I think if they see performed by the expert, definitely I think it would help them.
Okay, so you're the boss. Third week sessions, you're the boss. I'm only in charge the first week Sunday.
No, sir. Whenever, because before this examination, because they may be having examination in the September-October month. I think before that, at least we could have at least one class on this, especially
BMC
infant
is having one
examination.
session, no? BMC is having end of July. They're having what is that? ITC, intensive training for examination.
Intensive training, yes, sir. Intensive training.
That they have all these demonstrations.
Yes.
So
Yes,
they've
sir,
got
definitely.
faculty from all over the place, so no problem.
Yes, sir, definitely.
But I think all these people who are online are not local people, I think. The PGs, 56 people?
Yes, sir. There. Half of them.
Many
are
of them may be from
local.
outside.
Yes, sir.
Local also.
Outside, combination of both, sir.
So, Dr.
So what
Chandrasekhar,
I suggest is you have an online and hybrid. One PG presents and demonstration is captured, and for the benefit of PGs, they can see it online.
That is.
But it can't be tagged on to your monthly activity. It should be standalone. Because if you say third week, then you're in a hurry to receive the chief guest and say, sir, finish, lunch is coming, and I'm not a person to be tied with time.
Yeah.
Because
Well
if I
planned,
take a CNS class, minimum I need 3.5 hours. Minimum, with 10 cups of coffee.
Will plan, sir. Will plan, sir. Dr. Chandrasekhar, sir, any comments, sir?
Sir, I would like to comment. Nowadays, students have got two types of problem. One is mental constipation, another is oral constipation. Mental constipation is how to write theories. As sir has already explained, I will write the whole textbook like medicine, like a mathematics textbook. See, in the Department of Physiology, Anatomy, Biochemistry, where systems are not quarreling, so that is everything we should learn what is normal. When it becomes a disease, we should study under definition, etiology, pathology, clinical features, investigations, complications, and management. See, when I come to the clinical, this one, students should know we have got only 11 systems in our body. One is CNS, another is CVS, and if you keep the on the chest, you have got respiratory system. If you keep your hand on the abdomen, you have got 4 systems: hepatobiliary, renal, GIT, and reproductive, and musculoskeletal system. These are the 8 systems which you can see by your eyes, and you should know how to examine clinically in a systematic way. There are 3 systems in your body. One is hemopoietic system, endocrine system and metabolism, immune system, which you cannot see. But you have to know their problem by examining these 8 systems. If the students come to know the 11 system we should concentrate, you can reproduce the whole textbook. When you are doing the general physical examination, you should never forget 5 things. One is ENT, another is eye, another is skin, another is ulcer, another is swelling. You should never, for each one of us will give a clue what is the problem inside the body. And always I teach like this: local etiology, other systemic etiology; local pathology, other systemic pathology. See, suppose if I ask a question, what are the complications of pneumonia? Local: respiratory failure, lung abscess, pleural effusion. Now, respiratory system into CNS. There is meningitis. Respiratory system into CVS, myocarditis. Respiratory system to musculoskeletal system, osteomyelitis. Respiratory system into hemopathic or this one, septicemia. Like that, if you answer, students can remember much better, sir. This is how I make the whole medicine textbook of Nelson in 25 pages. You can reduce, and students will have a very good this winter. So study.
Thank you, sir. So nicely summarized, I
The
think. Yes.
the last tip I'm going to tell you is, as students of medicine postgraduates, very often CNS case, they are looking for a case with abnormal findings. So what I tell is, practice normal neuro findings in a normal child first.
Correct, sir. Correct.
If you see 100 children normal, then you will pick up one abnormality. If you wait for that one abnormal patient, that will be most difficult to examine, and you give up. Oh, this child is very difficult, you give up. So presume it's a CNS scan, do all the CNS. In fact, in my day-to-day rounds in the ward, I don't demonstrate abnormal CNS at all. When any child has come bystander for another child with vaccine, I bring that child. I say demonstrate power. So sometimes I use the PGs only as a guinea pig. So you must practice these things on normal and then before you go to abnormal. What is lacking is the PGs are not oriented to exam. All they want is, sir, give me questions, what will come in the exam, and what answer I should tell. End of the story. They don't want anything else. Times have changed. So you must practice. Otherwise, there's no answer.
Correct, sir. Correct, sir.
The common sense, they're not applying, sir.
Yes.
They're not applying common sense.
Yes, sir. If there are no any further comments or questions, I think we'll wind up, sir. I'll give vote of thanks. First and foremost,
Once again, Sunil, somebody
sir.
wanted these slides. I'll share it in the group. You
Sure,
please
sir.
forward it to them.
Fine,
This
sir.
video is also free. You can share the link to them.
Sure,
It's on
sir.
YouTube. They can revise.
Right, sir. I'll do it, sir.
Yeah.
Sure.
Yeah.
So on behalf of IAP Bengaluru, first and foremost, I thank our IAP President, Dr. Raghunath CN, sir, in his absentia for continuing and doing a wonderful sessions every first Sunday of every month. Secondly, I would like to thank Dr. Nagbhushana sir, who is the convener of this program, along with Dr. Subba Rao sir, and the star for today, Dr. Subba Rao sir, for doing such a wonderful job. Sir has told the not only art, sir has told even a lot of internal tips for clearing the exams as well as knowing the examiner's mentality as well. I would like to thank convener for today, Dr. Rajendra, the seniors in the audience, you can say, sir, Dr. Sarala Sabapati Madam, Dr. Chandrasekhar sir, Dr. Usha BK, Dr. Saravanan, Dr. Suman MG, and all the participants of this program. Thank you very much.
Thank you.
Sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, everyone. Huh?
Thank you.
Thank you.
I'll stop the
Thanks.
stream.
Thanks.
Thank you.